uh, very informative session today, and a warm welcome again to Dr. Jewell Joseph, who has already enlightened us on a very important topic of pain. So, Dr. Jewell Joseph, warm welcome to you. Dr. Jewell Joseph is an assistant professor in Christian Medical College, Jewell, and he's also a faculty in various other important courses. And his main interests are in community palliative care and home-based care. Warm welcome again to Dr. Jewell Joseph. The floor is yours.
Thank you so much, ma'am. Very good evening to all. So without wasting much time, I shall share my screen. Is my screen visible?
Yes.
Sure. Okay. Again, good evening to all. Nice to see you all again. So today we'll be very briefly discussing emergencies in palliative care. See, the title itself may seem a little bit ironic. When I tell this to some of my friends, they'll just ask me, what is the emergency in palliative care? You guys have everything under control and the patients are, the set of patients that we have, the general perception is that we don't come across much emergencies. So that is not the case actually. So what I'm trying to do here is see emergencies in palliative care in the sense like in all medical specialties, there are various emergencies, right? So all these things can actually come in palliative care. So it is impossible to cover every one of them in a single session. So again, as my previous session, what I'm trying to do is to give you an overview of the various emergencies that we face in palliative care and the basic approach that we take towards each of them. So coming to the definition of emergency. So basically an emergency is a situation that poses a threat to either patient's life or his quality of life without an immediate intervention from our side. So that is how we classify emergencies. See, as I mentioned earlier, that the way we approach emergencies in palliative care is a little bit different from what the other specialties do. So as I mentioned earlier, I remember hearing Dr. Twycross, who is one of the pioneers in palliative care, say in one of his talks, he says that anybody who hasn't passed tools for the past 5 days is a medical emergency. So it may not actually come in the typical definition of an emergency, but it poses a serious threat to the quality of life. So the way we approach emergencies in palliative care is that, so anything that poses a serious threat to the quality of life, we have a certain urgency in dealing with that problem. On the contrary, so even in certain situations, even a very serious emergency that might immediate attention and intervention in other specialties, we may decide to observe and watch. So, for example, in a dying patient, a patient who is expected to pass away very soon, you find that the patient has suddenly developed weakness of right lower limb, something like that, and you suspect a spinal cord compression. You know that spinal cord compression is a medical emergency, something that has to be dealt with very urgently. But since the patient is expected to die soon and the patient is completely bedbound and he or she is not expected to ambulate further, so in that case, we may just provide supportive care to that patient. So it actually varies to the situation. So anything, just because you have a hammer, you don't have to strike down every nail you see. So that is the general principle that we follow. So deciding us regarding what to do or when to do an intervention. So these are certain things to consider. So in the beginning itself, what I'm trying to tell you is we have to identify risk early. So we have to anticipate what all the emergencies that we may face in the course of the illness, so that we can actually prepare the patients and the relatives, and we can prepare ourselves to brace ourselves to handle such a situation. The thing I wanted to mention here is that in palliative care, In many situations, the most important, the most difficult part of dealing with an emergency is actually preparing the patient and the family to accept that thing. So in many situations, we may not be able to do a lot of things. For example, in a terminal patient with a terminal cancer, when the patient is having a massive hemorrhage, we won't be able to do much rather than to support the patient and comfort the patient. So a very big part of dealing with emergencies, especially in palliative care and especially in patients towards the end of life, is actually preparing the patient and family to face such emergency. So anticipating the emergency earlier and proper communication and proper preparation will actually go a long way in managing these emergencies effectively. Second thing, once a situation has occurred, the so-called emergency has occurred, the next question that we should ask ourselves is that, is it reversible? So if it's not reversible, there is no point in going very aggressively at it and causing additional morbidity to the patient. So the second question to ask is whether it is reversible. Third one, is there a meaningful benefit? So as I mentioned earlier, in a dying patient who has suddenly developed right lower limb paralysis and you're suspecting a spinal cord compression, but there is no point in doing a set of investigations and doing a surgery or radiotherapy or whatever. So we treat emergencies only if it provides a meaningful benefit to the patient. And the fourth thing, and a very important thing, is what does the patient family. So we actually, in palliative care, as I mentioned in my previous class, we try to be patient advocates. So, so we just don't treat everything. So considering all these things, we actually take into account the patients or families' opinion also regarding what to go about. So in palliative care, these are the things that will guide you regarding how to go about a situation or an emergency that occurs. So emergencies, as I mentioned earlier, any medical emergency can occur in palliative care. So I have just broadly classified it into various classification based on the system. So neurological system, the main emergencies that we deal with is spinal cord compression, increased intracranial tension and delirium. Respiratory system is mostly airway obstruction, vascular, superior venal caval obstruction, hemorrhage, metabolic like hypercalcemia and hyponatremia, and skeletal events like pathological fractures. And one important thing is pain, regarding pain crisis and opioid overdose is another important example of a palliative care emergency. See, as I mentioned, this is impossible to cover in one session. So I'll just go about with a selected few of these so that we get a basic idea. And you may all be very well aware of come across this in your medical practice. So it's just take it as a revision session, nothing other than that. So, sorry. So we'll start with malignant spinal cord compression, probably one of the most common medical emergencies, I mean, the emergencies that we see in palliative care. So malignant spinal cord compression occurs in 3 to 5% of cancers. It can be due to solid tumors or due to hematological malignancies. Most common solid tumors include prostate, lung, and breast. Hematological malignancies, most common example is multiple myeloma, which primarily affects the plasma cells and bones. Most common site is the thoracic spine. So see, thoracic spine is the most common site due to a number of factors. First thing, it is the spine. Thoracic spine occupies the most area. I mean, the most of the length of the spinal cord, because there are more thoracic spine. Most of the length of the spinal cord is occupied by thoracic spine. Second thing is thoracic spine. Due to this area, it has direct contact with breast, in the sense breast, the collaterals from the veins from the breast to the azygous vein communicates directly with the Bateson's venous plexus around the thoracic vertebra. So breast cancer is most likely to metastasize into thoracic spine. Another thing is lung, which is also can easily metastasize into the thoracic spine. Since lung and breast are the most common cancers in males and females respectively, and they are the most common. They are among the most common causes of spinal metastasis. Then thoracic spine is the most common site of malignant spinal cord compression or vertebral metastasis. Whereas in prostate, it can actually go more common into the vertebral lumbar spine and the pelvis. And one more thing, important thing to consider is that among the patients who are having malignant spinal cord compression or spinal vertebral metastasis, 1/3 of the patients have more than one site of either cord compression or vertebral metastasis. So the most common, it can actually cause pain, mechanical instability of spine, and neurological deficit. So this is a brief discussion about the pathophysiology of the spinal cord compression. So you can see in this diagram. So there is actually a staging system for spinal cord compression, where initially the tumor is outside the thecal sac, then it indents the thecal sac, then it enters the thecal sac. It actually goes around the intrathecal space and finally causes spinal cord compression. The basic pathology here is there is compression of the venous structures in the intrathecal space, and what causes is there will be resulting venous stasis. So when there is venous stasis, there will be vasogenic edema. Along with vasogenic edema, there will be increased secretions of interleukins, prostaglandins, various amino acids, etc., which can eventually lead to ischemia and finally will lead to spinal cord infarction. So this is the basic pathophysiology or the natural history of spinal cord compression in a malignant setting, of course. So see, the thing is, mostly I am dealing with malignant causes here. The signs and symptoms of malignant spinal cord compression. The most common symptom is back pain. Again, another important thing to note here is that back pain occurs in spinal cord compression usually well before the onset of neurological symptoms. So this can be an early indicator of spinal cord compression. One more thing I'll tell you is whenever a patient with a malignancy develops a back pain, new onset back pain, it is malignant spinal cord compression unless proved otherwise. So the importance of picking it up early is that the pain occurs usually much before the development of neurological symptoms. And once neurological symptoms develops, it becomes more difficult to reverse it even if we go in with the treatment. So back pain in a patient with malignancy, always take it seriously. Second thing is radicular pain, because there may be some irritation of nerve roots. It can occur in 40% of patients. And then comes the neurological symptoms and autonomic symptoms like bowel and bladder dysfunction, etc. There may be a spine tenderness in clinical examination where there is a fracture or something. And examination wise, there may be neurological and autonomic signs. So there may be a decrease in power. There may be a change in the reflexes, loss of sensation, loss of tone. Again, bladder and bowel disturbance, all those things can be there. So diagnosis, the gold standard is MRI, obviously. X-ray has value, but again, it will not give you any idea about cord compression per se, but it is useful as a very quick investigation to find out whether there is any obvious fractures and all. And the important thing is, whenever you go about an X-ray or an MRI, always screen the entire spine. So that before I mentioned earlier, among 1/3 of these patients, they will have more than one site of either spinal metastasis or spinal cord compression. So always screen the spine and not just concentrate on the area where the patients have symptoms. So coming to the treatment, the first thing is we should ask the patient to take complete bed rest, because if there is a fracture or anything like that, we don't want it to move around and cause further damage. And the second thing is analgesia. We can give opioids and adjuvants. What about NSAIDs? That is one question that I wanted to ask you. I'll just put it as a question mark here, and we'll come to that. There is obviously, if there is a bone disease or a bone fracture or something, NSAIDs seem to be the first choice. They work very well in all these situations. But in this thing, in this particular scenario, I'll just put it as a question mark, and then we'll come to that in later. So bowel and bladder disturbance, obviously we may need to give laxatives, digital rectal evacuation, catheterization for urinary incontinence, etc. So coming to the treatment. So treatment is ideally the treatment of the cause. The most important thing that we used to do first is give the patient steroids. So as I mentioned earlier, the primary pathology of malignant spinal cord compression is vasogenic edema and inflammation, causing infarction eventually. So steroids, as we all know, can decrease peritumor edema and inflammation in general. So steroids is actually the first line of treatment. This is the same reason that I put NSAIDs in a question mark, because as you might have finished the pain classes, right? So you must be aware of the fact that NSAIDs and steroids together we will avoid as whenever possible, because there is an increased chance of gastrointestinal bleeding. So whenever steroids are given, so we should probably stick to paracetamol or opioids. So surgery has a spinal instability. So fixing the spine is another option. Radiotherapy and chemotherapy. Palliative radiotherapy is an excellent option for pain control and disease control. Chemotherapy in certain conditions like lymphoma or multiple myeloma for that matter. Hematological malignancies respond very well to chemotherapy. Such situations, chemotherapy is also an important tool. So I'll come to that in each topic in detail. Steroids, as I mentioned earlier, it has anti-inflammatory and anti-tumor effect. The primary effect that we are looking in this scenario is anti-inflammatory effect and decreasing anti-edema. But having said that, in diseases like lymphoma, it has an excellent anti-tumor effect as well. The usual dose that we give is 16 to 24 milligram per day. So once the definitive treatment is initiated, we can actually try and taper it down, and always provide gastroprotection with protonome inhibitors, and try to avoid the use of concurrent non-steroidal anti-inflammatory drugs along with steroids. So other treatment options, as I mentioned earlier, radiotherapy. There are multiple fractionation schemes of radiotherapy, which are actually out of scope of this discussion. But it can either be given as a fractionated radiotherapy. That means that the total dose can be divided into multiple fractions, or in certain conditions, we can give a single fraction of radiotherapy as well. Surgery for fixation and chemotherapy for disease control, as I mentioned earlier. So the prognosis, again, the most important thing to consider here is that the most important prognostic factor in spinal cord compression is pre-treatment ambulatory status. So once the neurological deficit develops, it is actually very difficult to reverse it. And again, once a neurological deficit develops, the treatment should be as quick as possible. Again, another most important prognostic factor is the time of initiation of treatment from the onset of motor deficits. Ideally, it should be as soon as possible, minimum before 48 hours. So after 48 hours of development of neurological deficit, it is very difficult to reverse it. So this is why back pain in a malignancy patient should be considered, taken very seriously, because it can be a sign of malignant spinal cord compression, which occurs much before the development of neurological symptoms. So next thing is increased ICT, intracranial tension in CNS. So it can actually occur because of metastasis to brain or meninges, or it can be because of a primary brain tumor also. So as you all know, the most common cancer of a brain is a metastasis to brain, not a primary tumor. So that is why I have put it on top of primary brain tumor. Again, the most common malignancies causing brain mets are lung, breast, and melanoma. Symptoms will be, you all will be familiar with symptoms of increased ICT, headache, vomiting, altered sensorium, diplopia, all those things. See, the vomiting here can be, we typically say that increased ICT causes projectile vomiting. It can actually be non-projectile also. So just vomiting alone can also be a symptom. So treatment, again, as I mentioned earlier, steroids, because it reduces, because whenever there is either a primary tumor or a metastasis to brain, there will usually be a peritumor edema, and there will be some surrounding inflammation also. The steroids will take care of that. And often in patients with increased intracranial tension due to meds, steroids have some drastic effect in many situations. Osmotic diuretics, although we have been using osmotic diuretics like mannitol for the reduction of increased intracranial tension for a long time, and we still use for that matter. But the recent studies have suggested that in brain mets or brain tumors, the effect of osmotic diuretics actually plateaus off very quickly. So that is not a very strong recommendation nowadays, but steroids are. Next, other definitive treatment options would be surgery, radiotherapy, and chemotherapy. Surgery, if there is a primary brain tumor, single tumor, we can actually excise it. And even in brain metastasis, if there is a single metastasis, surgery is an option. Radiotherapy can either be a stereotactic radiotherapy or whole brain RT. When there is a very metastasis, that means very small amount of metastasis, very small number of meds for a single med, then we can do a stereotactic radiosurgery, where we give a very concentrated amount of high dose of radiation to that particular thing. Or if there are multiple meds, then we can give whole brain radiotherapy, where we irradiate the entire cranium with a comparatively smaller dose. So again, chemotherapy and targeted therapy are also options. So chemotherapy, the problem with general chemotherapy is most of the chemotherapy drugs doesn't cross the blood-brain barrier, so they may not be much effective in brain mets, but there are drugs that do also. And targeted therapy, especially in diseases like carcinoma lung, there are new targeted agents which actually causes the blood-brain barrier, which can provide even in carcinoma breast, drugs like lapatinib causes the blood-brain barrier, and it can actually cause the reduction in the brain meds. So analgesics again, paracetamol and NSAIDs are the preferred agents here. NSAIDs, if you are not giving steroid, again, avoid them if you are giving steroids. The problem with opioids is theoretically all opioids will increase the chance of seizures. They will decrease the seizure threshold, and tramadol is especially notorious in that regard. So if you are using opioids, it is preferable to use morphine, although it theoretically has a risk of decreasing seizure threshold. Adjuvants can also be given. Adjuvants in the sense any because there is a neuropathic element of this pain, any anti-epileptic drugs that we usually give can also be an adjuvant drug. And one thing to consider here is that usually we give antidepressants as adjuvant drugs like amitriptyline and all those things, right? See, and again, theoretically, all antidepressants decreases the seizure. Antidepressants decrease the seizure threshold. So you have to keep that in mind also when giving adjuvants for patients with increased intracranial tension. All opioids can theoretically decrease the seizure threshold. All antidepressants can theoretically decrease the seizure threshold. So, but we usually give morphine. Usually we avoid tramadol also because it is notorious in increasing the intracranial, decreasing the seizure threshold. So coming to the respiratory system, the most obvious thing would be airway obstruction. It can be due to an intrinsic or extrinsic compression by a tumor. It can be either acute or subacute. So subacute airway obstruction will have a gradual course. It usually will, we can usually identify them with shortness of breath, and there may be stridor also. Stridor is typically an inspiratory finding. So management is again oxygen, steroids. See, everything, everywhere there is an obstruction in general in palliative care or compression with a tumor, steroids have a role because they all reduce the and which will actually provide some relief to obstruction. Even in intestinal obstruction, airway obstruction, increased intracranial tension, spinal cord compression, nerve compression, all these things, steroids have a role. And for shortness of breath, you can actually try opioids and benzodiazepines. Opioids, especially strong opioids like morphine, will actually reduce the work of breathing. So there is a general fear about giving opioids in patients with breathing difficulty or respiratory compromise for fear that it can actually cause respiratory depression. It is true that opioids can cause respiratory depression, but in oral route, it is actually very rare, especially in a very, even in an IV route, if it is titrated very diligently, it is actually very rare. See, the thinking behind giving oral opioids, thinking behind saying that oral opioids are usually safe is that, see, it is very difficult to reach that particular blood level of oral opioids to cause respiratory depression unless someone is taking it with the intention of self-harm. So in a carefully titrated situation, scenario where oral opioids are given, respiratory depression is extremely rare. And opioids actually provide a lot of relief for these patients by reducing the work of breathing. And it property also. That is the reason why we give opioids in myocardial infarction also. It actually reduces the pain and it also alleviates anxiety. For the same reasons, we can consider benzodiazepines also. When the patient is very anxious, it can actually aggravate the breathlessness and the distress. In that case, benzodiazepines can be useful. Radiotherapy, again, it can actually reduce the tumor and prevent and reduce the obstruction, reduce the tumor size and reduce obstruction. So coming to the question of tracheostomy, whenever there is an upper airway obstruction, tracheostomy appears to be a natural choice, right? So whenever somebody comes with an upper airway obstruction, the next step is to go in and put a tracheostomy. So in patients with advanced cancer with a poor survival, you think twice before doing tracheostomy because it can actually add to the suffering of the patient in the coming days. So it has to be an informed decision. And this is why it is important to anticipate all these conditions early. So an early palliative care referral or an early meeting with the people, with the treating oncologist and the treating team to foresee all these effects and anticipate. See, it is very difficult to convince a patient who has been suddenly brought to the casualty with severe breathlessness that the tracheostomy may be counterproductive. It is very difficult to communicate in that situation. That is the importance of identifying these risks early and preparing the patients and complications that may occur in the future. So acute airway obstruction is severe progressive dyspnea and hemodynamic collapse. So unfortunately, in this situation, there is nothing much that we can do to remove the cause of the obstruction. So what we can do in this situation is sedate the patient so that there is not much distress and support the family and educate the family regarding how to tide over this time of stress. So in a severe progressing dyspnea, there is a sudden complete obstruction of trachea or something like that. There is nothing that nothing much we can do to remove the cause of obstruction, but we can again try our best to comfort the patient and give support to the family. So another important thing, we are coming into the vascular emergencies. One of the important thing that we see is SVC obstruction. So you must all be very familiar with this condition. You must have all seen this. This is the typical finding of an SVC obstruction. There will be dilated veins in the upper chest, and there will be facial edema. There will be conjunctival edema. Severe cases, there may be cerebral edema as well. So this is the clinical picture that we usually see in SVC obstruction. There is elevated JVP, which is actually pulseless. Classical MBBS Viva question, right? Pulseless JVP is seen in SVC obstruction. So the most common cause of SVC obstruction are bronchogenic carcinoma, lymphoma, mediastinal tumors. So again, the treatment, wherever there is an obstruction, there is a role of steroids. Again, radiotherapy and chemotherapy. Bronchodilators can be tried. Diuretics, the idea of diuretics is that to reduce the venous return and all those things, but again, the role is questionable. See, the one important thing that I didn't mention here is SVC stenting. So that has actually emerged as the first line treatment for many of these patients. See, the problem with steroids is steroids actually is very good in it offers very good symptom relief in SVC obstruction. But usually what happens is some patients may present with an SVC obstruction as the primary presentation. So some malignancies can actually present with an SVC obstruction at the primary presentation. So whenever we won't have a biopsy then, I mean histopathology then. So it is very important that if we suspect a lymphoma, steroids are contraindicated, because if you give steroids in diseases like lymphoma, it can actually change the morphology of the tumor, and we may not get a proper cytology. So in such situations, we may not be able to give steroids also. So SVC stenting is actually a very definitive kind of treatment. So that has actually come up as a new treatment option in the recent years. So again, what treatment to give should be a multidisciplinary discussion, family also, and we have to proceed accordingly. So these are the options that we usually have. So one practical thing that we usually tell the patient, we follow is we should not give any IV through the upper limb, because it will actually increase to the volume load in the upper limb, which cannot actually go through the heart because of the SVC obstruction. Again, SVC obstruction is classified based on the level of obstruction also. That is again much above the scope of this discussion. So just be aware that these are the treatment options available for SVC obstruction. So again, keeping the patient propped up will also help, and obviously no IV through upper limbs. So next thing is hemorrhage. Next thing in vascular thing. So hemorrhage can occur because of tumor infiltration into the blood vessels and bone marrow infiltration due to the tumor, resulting in thrombocytopenia. So it can be either a minor bleed or a major bleed. So again, as I mentioned earlier, is something related to something similar to subacute and acute respiratory obstruction. So minor bleeds, we can actually try and do something. So general measures includes transfusions, vitamin K, fresh fluorescent plasma, etc. And bleeding control, hemostatic RT and tranexamic acid. Hemostatic RT in the sense we'll give radiation to control the bleeding. Again, site-specific measures like APC, steroid and sucralfate enema in radiation proctitis, etc. can be done. So these are the measures for minor bleeds. APC is argon plasma coagulation. So major bleeds, again, very difficult to manage in the sense, see, for example, it can be due like from the major blood vessels, like a carotid blood vessels due to a head and neck tumor eroding into the blood vessels, or an inguinal tumor or a lymph node eroding into the femoral vessels. All those things are actually very difficult to control the bleeding per se. So what we can only give is just to give the family support and keep the patient comfortable. So we'll give opioids and sedate the patient, and we use dark towels. So mostly to prevent anxiety among the caregivers, because the sight of massive bleeds actually is very, very distressing to the patient and to the caregivers. So we use dark towels and we just hold hands and support the family. That is all that we can do in this situation. So Next thing, pathological fractures, again, very common thing that we deal with in palliative care. So it can be due to metastatic bone lesions in lung, breast, and prostate, and primarily in multiple myeloma, where the initial disease itself. So treatment is again surgical fixation, most obvious thing. Bisphosphonates and denosumab, these will actually try to increase the bone mineralization and strengthening the bone. Again, analgesia and adjuvants, because bone pain will actually have severe pain. So do you remember that I mentioned in my previous discussion that bone pain always have some neuropathy component as well. So adjuvants in this condition will be usually very beneficial. So pathological fractures, one important thing is it is very risk identification, as I mentioned earlier, which is important in all these emergencies, becomes very important in pathological fractures, because once a fracture occurs, see, in a metastatic disease, even if there is a fracture occurs, there may not be nothing much that we can do other than supporting the patient, because if the bone is, there is a lot of osteolytic lesions in the bone and the entire bone is actually very weak, it is actually very difficult to fix the bone. So fixing a very brittle bone is actually very difficult. So sometimes we may not be able to do anything also. Otherwise, the general condition of the patient may be very bad. So surgery is not always an option, but so that makes risk identification even more important in this set of patients. There is actually a scoring system called Mirror scoring system, which actually predicts the risk of pathological fracture. So it actually takes into consideration various factors like the site of the lesion, the bone lesion, whether there is pain, X-ray appearance of blastic, mixed or lytic, size of the lesion, etc. So obviously, weight-bearing bone will have more weight-bearing bones will be more predisposed to fractures. Where there is if there is functional pain, it is again a sign that there is an impending fracture. Lytic lesions obviously will be more prone for fractures. And size of the lesion, if more of cortex is involved, there is increased chance of fracture of the. So this is Mirror scoring system. If the total score is more than or equal to 9, there is, prophylactic nailing is prophylactic fixation is indicated in this patients. That is about pathological fractures. So now we are coming to malignant bowel obstruction. Again, it occurs in 3 to 5% of the patient. It can actually occur anyway from esophagus to rectum. The most common site of malignant bowel obstruction is small bowel. Interestingly, the most common of bowel obstruction itself is not a bowel cancer itself. Ovarian cancer is the most common cause of bowel obstruction, because the peritoneal spread of ovarian cancer, transcoelomic spread that we have studied in our UG days, is very common in ovarian, followed closely by colon cancer and others. In an advanced cancer, it is prognostic factor. The median survival of a patient with malignant bowel obstruction and advanced malignancy is just 1 to 3 months. So again, malignant bowel obstruction can be classified as partial and complete, which is very obvious from this diagram. And there can be a single level of obstruction or multiple level of obstruction. So basic pathophysiology here is there will be obstruction, and obstruction will cause a proximal distension. Proximal distension. So whenever there is an obstruction, the body will try to push harder against that obstruction and pass the food through that obstruction. There will be increased peristalsis, increased secretion. The increased secretions will cause increased gas. So secretions, gas, and all this will again increase the proximal distension, and that will actually go as a vicious cycle. So there will be pain, bloating, nausea, and vomiting. So as this goes on, so this obstruction and distension happens, and finally there will be inflammation. So when there is inflammation, there will be edema, and bowel edema will cause vasogenic edema. There will be decreased bowel supply. Sorry, there is decreased blood supply to the bowel, and there will be stretching of bowel, which cause stretching of blood vessels. All these things will happen. There will be distension, inflammation, and bowel edema. And finally, when the edema goes on for a long time, and it will eventually go into ischemia, and finally go into necrosis, which results in perforation and peritonitis, sepsis, and multi-organ dysfunction. So that is the basic pathophysiology and natural history of bowel obstruction. So based on the level of obstruction, the symptoms also actually may vary. The symptoms in these patients can actually give us a clue about the site of obstruction. In proximal bowel obstruction, the pain will be more in the upper region of the abdomen. whereas in distal obstruction, pain will be more central and lower abdominal, colicky kind of pain. So in proximal GI obstruction, the vomiting is early and severe because see, whenever there is an obstruction in the stomach, the easy way is to vomit it out. So body will just take it out through the mouth. So there will be early and severe vomiting in proximal bowel obstruction. And distal GI, the vomiting is very less because when it is lower down, body will actually try to push the contents down to the anus other than take it all the way up and pass it out through the mouth. So unless there is a profound, prolonged obstruction in the distal GI, the vomiting is actually much less when compared to the proximal GI obstruction. Distension is usually absent in proximal GI because anything that accumulates will be actually taken out through vomiting. And distal GI, distension is usually more pronounced. Constipation is less in proximal GI and more in distal GI. So investigation, see, X-ray is the classical thing that we do to confirm bowel obstruction. There will be air fluid levels, and we can find out the cause of obstruction with 93% sensitivity and 100% specificity. But in a terminal patient, I mean, in a patient with an advanced malignancy where we are not planning to do anything surgically and a surgical intervention is not probable. So the question of the value of CT is questionable. So one other investigation to consider here is serum electrolytes, which may actually give, because of if there is significant vomiting and all, there may be some electrolyte imbalance. So this is a classical X-ray picture with multiple air fluid levels, which is suggestive of bowel obstruction. So again, we manage bowel obstruction by non-pharmacological measures and surgery, pharmacological measures, etc. So non-pharmacological measures is rest the gut. See, the thing is, interesting thing is most of these obstructions that we present as, most of these cases that present as bowel obstruction are not complete obstructions. Actually, they are actually partial obstruction. So if we rest the gut, it is said that 1/3 of the patients with bowel obstruction will actually spontaneously get better if we rest the gut. So that is the first thing to do. We can try sips of fluid. IV hydration may not be required in advanced cases especially. And NG tube, and see, the thing is, the holy trinity of bowel obstruction, as when I was actually studying my PG and UG, was whenever there is a bowel obstruction, keep the patient NPO, IV hydration, and NG tube. So in palliative care, we have a different approach. So NG tube is not usually useful unless there is a very large volume vomiting. And IV hydration in a terminal patient may not actually make a very big difference. And if the patient can actually take sips of fluid, very small sips of fluid, may actually keep the mouth wet, and it may not actually aggravate vomiting also if it is very small sips. So NJ tube, if there is a proximal obstruction, an NG tube, a nasojejunal tube is also one option to consider. So surgical measures are the gold standard: resection, bypass, and soma. So there are palliative measures like gastric venting and stents also. So candidates for surgery will be single obstruction, good response to anti-cancer treatment, localized disease, young patients with good performance status, benign cause of obstruction, etc. So coming to the pharmacological measures. So basically we divide pharmacological measures into 3. So which facilitate bowel emptying or relieve the obstruction, which prevent the secretions and prevent worsening of the obstruction. Third will be the drugs which treat associated symptoms. So facilitate bowel obstruction emptying in the sense, as I mentioned earlier, many of these obstructions may not be complete obstruction. They may be partial obstruction. These steroids, what happens is there can be reduction in the peritumor, edema, and inflammation, and there may be an opening above the bowel. Prokinetics just to push the content through the stomach. So when you give prokinetics in a patient with an obstruction, always be watchful about increase in colicky pain. So if you give a prokinetic to a patient with an obstruction and she or she has increased colicky pain, it is a danger sign. So we have to stop prokinetics. So if the initial facilitation of bowel emptying is not successful, the next step is to prevent worsening of obstruction, to prevent secretion. So we can use anticholinergics or somatostatin analogs like octreotide in this patient. So associated symptoms, we can give analgesics and antiemetics for this patient. The only thing to consider is, in a patient with bowel obstruction, oral opioids are contraindicated because it may actually worsen obstruction by inhibiting the peristalsis. So next, we'll briefly go to the metabolic causes as well. First thing to consider is hypercalcemia, one of the most common electrolyte imbalance that we see in palliative care. So lung, breast, myeloma, and lymphoma can cause. So there are many pathophysiological mechanisms postulated: increased parathormone-related peptide secretion, local osteolysis, excess vitamin D secretion. All these things are postulated as the mechanisms of hypercalcemia. So the clinical features are neurological features of like irritability, confusion, sedation, delirium, etc. GI features are anorexia, nausea, vomiting, and constipation, and dehydration. See, this dehydration, vomiting, and constipation, all those things with some delirium can actually point to hypercalcemia. So these are the various symptoms of hypercalcemia. So management is basically based on severity. So mild, moderate, and severe. So mild is actually when the serum calcium is between 10.5 to 11.9 milligram per deciliter. Moderate is 12 to 13.9 milligram per deciliter. Severe is more than 14 milligram per deciliter. So the important one thing I wanted to stress here is when you are measuring calcium, always measure serum albumin as well, because many of these patients may have hypoalbuminemia and we may underestimate serum calcium. So we have to correct the calcium level according to the albumin level also. So a normal calcium level may not be a normal calcium level until we measure albumin. So hypoalbuminemia with a normal calcium level may be still higher when we do the corrected calcium level. So always send serum albumin whenever you are sending serum calcium also. So treatment again is divided into three. See, in the sense, if it is a mild hypercalcemia, simple hydration itself may suffice, but moderate and severe hypercalcemia may require some drug measures. So the basic mechanism that we follow is increased calciuresis, so increased secretion of calcium through the kidneys, hydration, and diuretics. Diuretics also, we say that loop diuretics have calcium excreting effect. It is not a very effective thing on its own. So with combination, yes, but not on its own. Reduce parathormone secretion by calcitonin and reduce bone resorption, bisphosphonates and dinosonate, which will actually take the calcium from the blood and deposit in the bone. So all these things can actually help with the treatment. So hyponatremia is another important thing. So again, we divide hyponatremia as hypervolemic, hypovolemic, and euvolemic hypernatremia. So hypervolemic hypernatremia is most common in CCF and cirrhosis. See, what happens here is there is enough sodium in the sense what happens here is there is increased water retention in the body because there is inability of the heart to pump enough blood. So there is decreased renal perfusion, and there is also, due to the decreased pumping action of the heart, the carotid baroreceptors will also sense a decrease in the blood pressure, in the arterial pressure. So what happens here is the renin, angiotensin, aldosterone system will be suppressed, and there will be secretion of, the total sodium homeostasis, all those things will be disturbed, and there will be hyponatremia. So hyponatremia in a CCF patient is actually considered to be a bad prognostic factor. Hypovolemic hyponatremia is mostly because of vomiting and diarrhea, where there is an increased solute loss. Euvolemic hyponatremia is the thing that we come across in malignancy, syndrome of inappropriate ADH secretion. So what happens here is there is increased ADH secretion and there is increased free water reabsorption from the distal tubules. So the problem here is the volume will be maintained as euvolemia, because the other systems like the renin, angiotensin, aldosterone system and the atrial natriuretic peptide or ANP are functioning normally. So what happens here is when there is increased free water reabsorption from the distal tubule, when the total body volume, of blood volume rises, atrial natriuretic peptide will actually throw away sodium along with water through the urine. So what happens is the volume will be maintained, euvolemia will be maintained, but there is increased loss of sodium through the urine, and there will be hyponatremia. That is the reason for hyponatremia in SIAD. There will be euvolemic hyponatremia. So again, diagnosis hyponatremia less than 135 milliequivalent per liter is the diagnostic criteria. Symptoms usually happens less than 120 millicrons per liter. So that is actually the cutoff that we start treatment also. If it is above 120, we don't usually treat it aggressively. We just ask the patient to increase the salt intake. Life-threatening is less than 105. Symptoms can be anorexia, malaise, irritability, muscle cramps, all those things. Management, SIADH, simple water restrictions. As I mentioned, other systems are functioning well. So we just need to reduce the free water intake so that free water cannot be absorbed. The other systems will take care of SIADH in most of the conditions, where we can actually give 3% saline also, and tolvaptan, which is an angiotensin receptor 2 inhibitor, which is also used in the management of SIADs. And one thing, important thing to consider here is that correction should not be more than 4 to 6 milliequivalent per liter over 24 hours. If you correct more rapidly, there is a risk of pontine demyelination. One more point I want to stress here is that whatever be the sodium of a patient, if the patient is dehydrated, please don't give him hypertonic saline or 3% saline. So always look for the tongue, the skin turgor, etc., and to see whether the patient is dehydrated. If the patient is dehydrated, whatever be his sodium level, please don't give him hypertonic saline. Again, hypertonic natriumic correction, you might all be very familiar with this formula. So what we usually do is we actually find the deficit. So deficit is basically milliequivalents per liter. So we per liter the deficit we'll find out. We'll find out the total body water, and then we'll find the total deficit, and we'll actually calculate the rate of infusion along with the amount of hypertonic saline that we need to give. So pain crisis and opioid overdose, this is last but not the least into that, because you must have already come across this in your previous lectures. So I think I have just crossed the time limit, but I'll just give you the single slide alone. So take home message will be every condition that causes patient distress is an emergency, whatever it may be. The question to ask in an emergency is, will the intervention result in a meaningful benefit? If yes, go on with it, whatever it may be. But if it does not provide a meaningful benefit, so please don't chase it. So we don't need to chase every value, or we don't need to chase every symptom unless if it provides a meaningful quality of life. And as palliative care physicians and as people understanding the palliative care principles, so we are patient advocates, and the patients and families' wishes are to be upheld at any cost. So that is what we need to look to do. Thank you so much. Sorry, I have taken 5 minutes extra.
Oh, thank you. That's okay. Thank you, Dr. Jewell. Like it's a as you started off telling, this cannot be covered in whatever time. You can talk for one day also. You can go into each emergency and go in detail and explain. But you have given us an overview, like how each one can be managed. And your last slide is what really the take home. You have to see each patient and each situation appropriately, and then make a call what type of emergency management is required and in patient's best interest. That is the total nutshell of whole thing. And I liked your words, not only knowing palliative care, understanding and practicing palliative care appropriately. That is what is important, isn't it? Because first and foremost, the outlook of palliative care itself has to be understood very well. I think to a very great extent, things are changing in the world. People don't think as only end of life care is palliative care. That is not at all. So thank you very much. And let me see if there are any queries in the chat box. Are we talking about DEXA? What was the query, Dr. Akshita Agarwal? Can you, it says, are we talking about DEXA? What does she ask, whether it's in place of steroid, are they talking?
Okay.
It's my suggestion.
Yeah, okay, ma'am. Yeah. The thing that, see, whenever sorry, my bad. So whenever I tell steroid, please read it as DEXA. That is the most common thing that we usually do. So all these situations where I mentioned steroids, please understand that as DEXA. We don't usually give other steroids like prednisolone or hydrocortisone or something, but usually give dexamethasone.
And dexamethasone is what is, and quite a lot of oral also is used in practice, especially with difficulty with swallowing, many things, and it does wonders.
Yes.
And then, like in those type of patients, even a small benefit is appreciated. So I have in fact used it, and then it gives good amount of relief. And it's available. In between, it wasn't available. I hope it's freely available now again.
Yes, ma'am. Yes, ma'am. Freely available. The only thing with DEXA is it doesn't have a prolonged effect. Even though it produces drastic effect in the beginning, the effect of DEXA actually seem to wean off as weeks pass. So if you are actually having a patient, try to taper it off as quickly as possible and give it in pulses rather than a continuous long-term solution.
5 days, that's what, like just 5 days, like give it for a few days, taper it off, give a gap and then use that. That is where it will be beneficial. If you just continue, it will definitely not have the effect. And when you give it in pulses, it is very effective. We have to teach these to the patients. See, they will be attracted. Oh, it gave me relief. Can I continue? If we explain to them, they will also understand. Most of these things, no, awareness and explanation, us taking the time to explain to them will come very handy. Any other queries? Or we can go to the case presentation and have the discussion again. So Sri Priya, I think that may be a good choice.
Dr. Deepti? Dr. Deepti, do we have you?
I'm happy to do it. Go on to the next slide, Sri Priya. Okay, now we've got an 83-year-old patient, female patient, who the diagnosis was CA vaginal vault. Next slide, please. Present complaints were routine visit by palliative team noted that the bleeding seems to have worsened and that the patient was looking pale. Next slide. History of illness. The patient had developed prolapse of vaginal vault about 2 years ago, did not divulge it to anyone until she started seeing some blood stains in her undergarments. And then she had seen the local gynecologist who diagnosed prolapse of vaginal vault with a hard mass and an overlying ulcer also. Biopsy was done, basic investigations were done, and then it was ruled out that any definitive treatment, and then was referred to the palliative care team. And then she was managed at home by the palliative care team, consulted by the local gynecologist, and a vaginal ring pessary was tried. But it was not effective and beneficial. As the mass with the ulcer was constantly in a prolapsed state, she suffered from local pain, mild to moderate in intensity, and there was intermittent bleeding and occasional foul-smelling discharge also. And then she was advised to wear clean, tight underwear, and then was given tranexamic acid for the bleeding. Initially, it was given at 1 tablet thrice daily, gradually raised to 2 tablets thrice daily. And local application and nursing measures were also given. And all these gave only temporary relief. And then there were episodes of sporadic spotting from the ulcer. And then the hemoglobin was staying between 9 and 10 milligrams. Hematinics were also added on. Routine visit by palliative care team noted that the bleeding seems to have worsened and that the patient was looking pale. Discussed with the doctor and suggested hospitalization. And as her son was out of station on a job, they waited until that night, and then the bleeding was quite evident. So next slide. On examination, on arrival to the casualty, her vitals were fairly stable, but she was in severe pallor. Examination in the labor room revealed continuous, though not profuse, bleeding from 3 to 4 spots, and there was also a friable ulcer. Cautery was ruled out. Treatment and significant investigation. The ulcer was packed with gauze, and the mass was, to some extent, to what extent could be pushed in, was done into the vagina, and the vaginal pack was also done. And she was started with slow infusion of saline and glucose saline, and the hemoglobin was low, and it was 5 milligrams. Whole blood transfusion was started, and IV antibiotics were also given. The next day, 2 units of packed RBCs were infused and the vaginal pack was inspected. At that time, they found it was soaked with dried blood, and then they decided to leave the pack for another day. On third day, when it was removed, the ulcer area was very red and friable, but with no obvious fresh bleed. And the hemoglobin had gone up to 7 grams. And then they reapplied the pack, gave 1 more unit of packed red blood cells. And then the 4th day, 1 more unit was given. And after inspection, the pack was removed and the hemostatic dressing was applied. That was on the 5th day. Here, the psychological aspects, what to be considered are, and the patient was discharged with guarded prognosis. Lady was cheerful and beaming with a toothless smile. So basically, she was happy with what she received, and all throughout her stay in the hospital. Even though it was see, for us, we would think bleeding continue, but she had took it in a nice way. Next slide. The overall medications are, like we have seen, the ulcer was packed with dressing, then IV was given, and she had few units blood transfusion. And then again, the pack was re-inspected on day 3 to day 5, and then appropriate management was done. Next slide. What are the main discussion points? Bleeding in a cancer. So this could be internal or external. So as we have seen today, what are the different types of possibilities of bleeding that could happen? And these existing bleeds can be exacerbated by medications, which was also discussed in our discussion today, by non-steroidals, anti-inflammatory and anticoagulants. So you have to have all those in mind. And patient may develop a catastrophic bleeding. And then that bleeding could be mild, moderate, severe. So what is there? So you have to deal with it appropriately. Therapeutic interventions for bleeding should start by establishing the goal of care, and treatment choice should be guided by life expectancy and quality of life. That's what you have to give an overall consideration of everything. Careful thought should be given into continuation of medications and reversal of anticoagulants. Interventions to stop or slow bleeding may include systemic agents or transfusion, as what was done in this case. And non-invasive local treatment options should include like pressure dressing, packing, exactly what was done here. Next slide, please. So overall, we have had one of the emergencies which was mentioned in our discussion today is what has been brought up in this case. And as we were told by Dr. Jewell, you have to deal with it appropriately. I would leave it open for the rest to get involved and share their thoughts. Anything could be done differently or anything like that? Would anyone feel so?
Ma'am, I was thinking palliative RT, was it considered in this patient? I mean, I couldn't get it from this.
I would like see, as Dr. Deepthi is not a whether palliative RT, whether palliative
I couldn't find
RT,
it from this, ma'am, but for such bleeds, I mean, palliative RT maybe.
That's what. I was also about to say thing, whether palliative RT has a role here. Dr. Jewell, any idea you want to share? And then we can go ahead with that.
No, ma'am, the management there is actually quite nice, ma'am, as per the dressing and all medications and all those things are considered. But the only thing I wanted to suggest that there may be a role for palliative RT. Even a single fraction of RT would have helped in this situation. So
see, exactly, no, like because always RT, palliative RT will help, but here in her condition, whether what, because she was for palliative treatment, and then whether access.
That is a question. Unless we see the patient, that we cannot actually tell how difficult it is to plan and give RT. But it's possible that that would be a nice thing to.
Exactly, at least to avoid recurrent bleeds and things like that.
Yes,
And at that point of time, what was done was fine, because first dealing with the emergency is important. And then maybe if option was there, we could consider that before discharging her or something like
yes,
that.
yes.
Always, that's what say, even in any other forms, correcting the correctable. See,
Yes.
there are some golden statements in palliative care. The ethics of palliative care, correcting the correctables, and then where and when palliative care starts. If these ideas are well embedded in ourselves, the whole system will work. Many times that is not there. So even our help and effort should be to make sure these salient points are reiterated. Nothing wrong. We can keep on, like parrots, we can keep on telling the same thing as long as our goal and objective is achieved. So that is what will be beneficial. And I think overall, we have to look into things like that as and when. And each, this particular case, if you see, what they've done is best. She came in with a hemoglobin of, see, in these type of patients, we are not going to aim to get a hemoglobin of 10 and 12. So we also have to get our heads right in these situations. Her age, her condition, and getting her to a state where she can look after and do things for herself and not chasing numbers. Just chasing numbers generally also is not good. You have to consider as a full patient as a whole. And then especially in palliative care, it has to be very, very reasonable, appropriate. I can put many adjectives. So I will stop there. Among the, I'm just coming to overall all the emergencies that we have seen. Spinal cord issues, SVC obstruction. These are all very common. If you work or if you see many patients, many palliative care patients, and especially you have an inpatient, outpatient setup, those are the emergencies which you will see a lot. So, and bleeding is another very, very common thing. So these three will be there in large numbers when you see more patients. It all matters on the load of patients that you see, that you will encounter the various emergencies. And then appropriately dealing with them, explaining and doing things is what is the next step forward. Anything else anybody would like to ask Dr. Jewell Joseph, any queries or anything like that? Good. Like, see, it was quite a elaborate talk. He went into everything, and all of you have to be aware. I would say there are emergencies as in other specialities, and how you deal with them. That is the thing different. How, where, when. Those are the aspects which all of us have to have in mind. If there are no queries and everyone is happy with it, good. I think like always like that. When it is all clear, then we are all fine.
I hope it's not the other way around also.
No.
Either.
No, I never see, nonsense is never thought at all, Dr. Jewell. So only the right way forward.
Sure,
See,
sure.
don't give room for nonsense.
Sure, ma'am, sure.
Oh, and I have a lovely team. So they are interactive always. And then when required, they will jump in. So I have full confidence in them.
No,
so I'm not taking it the other way at all.
That was an excellent lecture.
Thank you,
It's
sir.
very
Thank you.
difficult to cover. It's a vast subject.
Exactly.
Yeah.
Yes.
Very surprising that you have done it in a short time.
Yes. It was like you didn't miss anything. You covered everything, and you gave a bird's eye view of everything. As Dr. Umapati said, I was also very impressed.
Thank you. Thank you so much.
Good. And the case also was appropriate to it. See, as we say, no, bleeding is one of the common emergencies we all see. And it is something is seen, and then something can be managed also. So we have to look into that in all forms. And as I said, no, the other ones will be only when you have more exposure to an inpatient setup, you will come to see the rest of them. So it all matters where and how each one of you are working, and you're connected with it. So in future, when all of you are going to have more insight and opportunities to work, all these will be there at the back of your mind when you see them. No, these are not strange. I have heard about it, and I know roughly to manage also appropriate. That is the way forward. Okay, Shripriya, then I will hand over to you then.
Thank you. I do believe that this is not the weekend fatigue which is keeping our participants on a silent mode today. And as you said, we do think positively. So yes, of course, the thank you messages which are coming right now in the chat box does show that the participants are active in the session, even
exactly
though the videos are turned off and the mics are muted. So when we do expect that you put on these feedback in the feedback link as well, just reminding that because recently our feedback numbers have been diminishing a little bit. So earlier, almost all participants used to give feedback, but for the last 1 or 2 sessions, the number have been diminishing. So please do take out some time to leave your feedbacks, because it helps us and our faculties to improve in the coming sessions. Because Dr. Jewell, thank you so much for joining, and we do hope to have more sessions with you in future as well.
My pleasure. Absolutely. I mean, absolutely wonderful thing. See, the only thing when I was telling the other way around, I was not doubting the team in any way. So I was just thinking whether that this was such a horrendous lecture. So everybody felt that there is no point in asking this guy anything more. That was the only thing that was going through my mind.
No, these emergencies are so many, isn't it? Oh, like, see, it's not an easy thing. Like literally from all systems you've gone. Cardiovascular, respiratory,
it's an absolute pleasure. It's an absolute pleasure to be with this team, an absolute pleasure. The learning experience for me also. I mean, I'm a relative newcomer to this field. So sharing a session with people like you and a wonderful team like this is always a great privilege, man. Thank you so much.
And as Shripriya said, no, this feedback is important because see, that from the feedback only, we better ourselves in the next program. So whatever are the plus and minuses you say, it's always we look at things like that is how the whole world keeps on improving. What you say is taken up and implemented in the next session or something like that. So always constant progress and improvement happens with a positive, with a good feedback. It could be either way. See, always anything right, okay, we'll continue. Anything to be corrected can be corrected, isn't it? So it's always not only me, it's the further future generations and future courses are going to get more benefited. So feedback is very, very useful, valuable. So please do fill in. So because that will help. Maybe you'll say to another friend to attend, and that friend will say, no, our course was still better than yours. So that's what. Something like that is what we are looking into. So please, all of you, couple of minutes, 2 to 5 minutes it will take to do that. So please do that and submit also.
And before signing off, just one more message. We have received a message from Dr. Deepthi, and she has apologized to the entire team. She could not continue with the session because of network coverage issue. So just wanted to convey that as well. So with a very positive note on a weekend, this is Shripriya along with Dr. Jewell Joseph and Dr. Ratha Venkateshan signing off from the Tips Eco Hub. See you in the next session after the Diwali holidays, because on coming Monday, we will not be having a session due to Diwali holidays. Enjoy Diwali, stay safe, be happy, And we will see after Diwali on 26th with another entirely different topic and a very young, active faculty. Till then, signing off from the Echo Hub, this is Sripriya. Everyone take care. Bye-bye.
Thank you. Happy Diwali to one and all.
Thank you. Wish you all the same.
Thank you.